Hello, and welcome to our 15th and final webinar in our AFBSS webinar series. Today's topic is financing and sustainability for AFBSS. And now, without further ado, I'd love to hand it off to our presenters, starting with Dr. Helen Duplessis.
It's really great to have everyone here with us today, and we have just an amazing panel, as you can see. I'm going to ask each of them to introduce themselves, and then we'll sort of jump into the material soon thereafter. Elise, do you want to get us started?
I'm Elise Jones, and I'm the director of Lake County Behavioral Health since 2023. And in dog years, that's like 100.
Hi, my name is Glenda Aguilar, and I work for the Orange County Healthcare Agency within the Behavioral Health Services in the Substance Use Disorders Division. I'm a licensed marriage and family therapist, and I have been with the agency for over 19 years. In my current role as a senior health services manager, I support anything SUD related, from programming to services throughout our continuum of care. Thank you.
Thanks, Glenda. I'm Helen Duplessis. I'm a physician principal in Health Management Associates, been with the organization about 8 years. Suffice it to say, since I've been at HMA, I probably spend between 40 and 60% of my time doing substance use disorder related work.
Good afternoon, everyone. I'm Mark Lorenz. I'm the Assistant Deputy Director over Substance Use Disorder Services at the Orange County Healthcare Agency. I've been with the agency, it's hard to believe, over 26 years. Started as an intern and just stayed, and mostly with alcohol and drug services, but also with prevention, intervention, and MHSA at the time. Happy to be here. Thank you.
Hi, all. Phoebe Bell. I'm the Senior Director of Housing Solutions at the California Mental Health Services Authority, or CalMESA. And previously, I was the Behavioral Health Director in Nevada County for a number of years.
And Ryan, round us out.
All right. Hi, everybody. My name is Ryan Caceres. I'm the Director of Behavioral Health Financing here with CalMESA. A little bit of background about CalMESA. We're a joint powers authority that was formed by the counties in 2009. And we serve in many different roles and capacities directly in support of counties, and especially in initiatives like this. Before I was with CalMESA, I was with Tulare County Behavioral Health. I was their budget officer, and I was with that Tulare County for about 5 years.
Spectacular. So as you can see, we've got an august panel, and they've all been there and done that, and some of them are still doing it. So as we go to our next agenda, our next slide, you'll hear from Ryan and Phoebe at the outset, giving us a little bit of the landscape on financing and sustainability for BHSA and for assertive field-based work. We'll hear specifically about some of the related resources that are available through CalMESA, and then very briefly through one of your other contractors, Boston Consulting Group. Then we'll we'll hear from our panelists. We very deliberately invited both a large county and a small county to be represented here on this panel. So you'll hear a little bit about their journeys. And on the next slide, got to have those learning objectives, and here they are. By the time you're done today, we hope you'll be able to identify at least 3 funding sources that might help you support AFBSS, 3 effective strategies, kind of high-level strategies for funding those activities, and then a couple of technical assistance resources that you'll be able to use, keep in your back pockets, share with your colleagues, that will support you with financing and sustainability, and then also that you'll be able to evaluate some of the local implementation needs that you have in this process. I know you've been doing that already. You'll get some additional best practices going forward. So I'm going to turn it over to Ryan at this point.
So what I'd like to kind of first touch on is that, in the content that we're going to go through here, we're not going to be able to solve the question of exactly how each county should finance AFBSS, because that answer is going to look very different depending on your county's existing programs, your staffing, contracts, your infrastructure, and things like that. Every county is unique. And so what we really want to do is we want to walk through the foundational pieces for how to consider making it all work, right? So we're going to talk through what makes AFBSS financially different. We're going to discuss the Medi-Cal billing realities involved in it, what types of activities may or may not be claimable. We want to, really walk through the funding sources that you may kind of go to first to consider using to braid in and make this model work. And then from there, each county is just going to have to take an honest inventory of how their current resources are already allocated and identify kind of what's the best way, what capacity is currently available to dedicate those already allocated resources into making this happen. And we're going to have some different ways of integrating the AFBSS model that we're going to touch on and things of that nature. But first, let's just go ahead and go to the next slide. All right, so financing assertive field-based services, like I said, is unique. And the reason that it's unique is that it's more complex than simply field-based Medi-Cal billing, right? It's not just services that are all billable in all contexts out there in the field. It's going to include activities that happen before, around, and sometimes outside of that traditional billable encounter, the way a lot of counties may think about it. Assertive field-based services is not a defined Medi-Cal benefit. When we think of a defined Medi-Cal benefit, we're thinking of something that, in itself is a bundle that is a Medi-Cal approved service. We've got actually a little key there that tells you defined Medi-Cal benefit means that it's a program that is specifically included in the Medicaid state plan. It's approved by the federal government, and it's an entitlement for eligible beneficiaries. Had to kind of ground myself with the definition there. So it's not a defined benefit. There's no all-inclusive bundle payment structure for this. The model is going to include both billable clinical services and non-billable engagement activities. We're going to take a little bit of a deeper look at that. And the Medi-Cal funding really, where that is available, it's still only going to partially cover the cost of delivering the service. As many of the folks in the audience are aware, that even when you're talking about something being Medi-Cal billable, you're still going to have that local county non-federal share that's going to be dedicated in order to braid in and draw down those FFP dollars. And then, AFBSS introduces an additional layer of financial complexity that we just have to confront. And, we've touched on some of that here. And the non-federal share for billable Medi-Cal service is one of them. And then the other one is just the full cost of taking those non-billable activities and making those components also all work together in the delivery of this service. So we can go to the next slide. Okay, so in the table here to the right, what we're doing is we're demonstrating that there are different parts of the AFBSS workflow, and they may have very different billing considerations, right? This is sort of a matrix to help us think about all of the things that are involved in the AFBSS service component, and how to consider whether or not there's some billing opportunity, really billing in the context of Medi-Cal. So in AFBSS, a lot of work starts before the county is in a clean position to bill. You may have staff that are out in the field. They're trying to find someone, they're engaging with them, building trust, helping them understand MAT, or getting them connected to treatment. That work is absolutely central to the model, but again, it may not be reimbursable in all contexts. So the question that counties really are having to consider is, can we bill Medi-Cal? Which parts can we bill? And what has to happen before that billing can occur, right? And then obviously the key to that is how are we going to finance those parts that do need to occur before billing may take place? So
that kind of way upstream early engagement work, I do think, and I assume most folks on this call are aware that DHS and has tried to support us in being able to be more capable of billing for some of that early work because it is so important. And I forget some of the numbers, but it's like research has shown it can take tens, even hundreds of contacts with somebody before they're willing to engage in sort of the next step of linkage to care. And figuring out how to bill for as much of that work as possible is really important. And using those Z codes and being flexible in how you consider somebody's engagement, I think is an important part of that. So just flagging that piece that while it's not traditionally super easy to bill for all the reasons you said, we do want to lean into that whenever we can.
yeah, thank you, Phoebe. All right, we can go to the funding streams. Okay, so now what we're going to do is, we've kind of laid out all of the moving pieces that are involved with assertive field-based services. When you've got the slide deck in front of you, you can kind of take that in, at your own pace. But when we consider that and all of the areas that may present opportunities to bill Medi-Cal, some of the areas that you would have to finance with your own local resources, then, we want to next sort of jump into what are those funding streams that, serve as a good foundational pillar for you to use to braid in. Again, acknowledging that many of these funding streams are already allocated. You've got resources that are constrained. And so, that's something that we definitely acknowledge. So the first one is that the Behavioral Health Services Act, BHSA, it's one of the more important funding sources to think about in this context because it fits directly into the broader policy direction of integrated behavioral health care, especially as counties are required to plan for mental health and substance use disorder services through the integrated plan. But I would not describe BHSA as simply a billing source. It's more of a planning and programmatic foundation. Counties can look at BHSA where the activity aligns with the most appropriate component rules, eligible populations, and the county approved plan. Because that's obviously one of the important considerations is that if you are using your BHSA dollars, then obviously the use of those dollars need to be in alignment with the way that you've got them laid out in your plan. And so, BHSA in that case needs to be used very intentionally. You've got to have some foresight and some initial planning in order to braid that in. Again, so it's in alignment with your 3-year integrated plan. 2011 realignment, it's also central because it is one of the most flexible behavioral health funding sources that counties already rely on to support both mental health and SUD services. It includes, from an AFBSS financing perspective, one of the most important roles realignment may play is helping support that non-federal share that we've touched on. So when a piece of AFBSS is claimable through Medi-Cal, counties still need to identify that local share, and to support that federal drawdown. Realignment often is a part of that conversation. So at the same time, counties need to be realistic because again, 2011 realignment's been on the scene for a long time and it's, you've likely got it obligated in various areas. We can go to the next slide. All right, so the next one is Medi-Cal patient care revenue. So as we consider that, again, the work that you're doing through AFBSS is going to have a lot of billing potential. And so as you're billing it, you're going to be drawing down Medi-Cal patient care revenue. And so it's very important, to have that involved in the sustainability conversation, right? But again, it only exists when a service is actually coverable, meaning that it meets the medical necessity documentation, it's claimed appropriately. But just like Phoebe touched on, there's definitely more and more opportunities to leverage Medi-Cal claiming using, just like she had kind of laid out, right? Z codes where possible and, just trying to maximize that to the extent possible. Substance abuse prevention and treatment block grant. So SUBG can be helpful for SUD services, particularly when counties are serving uninsured or underinsured individuals, or where the activity is not otherwise financed through Medi-Cal. The important thing here, though, is that SUBG has specific federal restrictions. So you want to be cognizant of that, and you don't want to, braid it in as the non-federal share for Title 19 services, right? Really, SUBG's intention is to finance those non-Title 19 services. When we say Title 19, we simply mean services you can bill to Medi-Cal, right? So you would think of SUBG as like an appropriate patch to come in for all of those things that are not billable, or for services that would otherwise be billable, but they are given to clients that are uninsured, right? So there's specific contexts that you use your SUBG dollars, and you've got to evaluate that carefully. Then we can go to the next slide. Okay, opioid settlement funds may be a strong fit where AFBSS is being used to address opioid-related needs, such as overdose response, MAT linkage, harm reduction, treatment engagement, or recovery supports. The important thing is that counties should be able to clearly connect the use of these funds, though, to the remediation activities as they're described in all of the related regulatory, nuances associated with opioid settlement funds. When you go and you look at those OSF agreements and the subdivision agreements, et cetera, you've got very specific uses that those dollars are supposed to be directed towards. And so you just want to make sure that if you are braiding in opioid funding, that you are using it in a way that aligns with those allowable settlement activities. And then finally, so Medi-Cal administrative and quality assurance and utilization review. So when we're thinking about administrative FFP, in the context of administration or QAUR, these are important, but they may be a little misunderstood. These are not direct service reimbursement streams. They may help counties recover the cost for the allowable administrative work and quality assurance work to the functions tied to the delivery of the Medi-Cal services from the AFBSS team, right? So when you think about that team out there in the field delivering those services, all of that is direct client care. It's not reimbursable through this context. But where this funding does play a role is you also have to have administrative overhead, quality assurance, things of that nature that are being done in the oversight of your AFBSS program. So, when you consider those overhead costs, also consider that when those costs can be tied to Medicaid eligible activities, then you will definitely be able to include those on your quarterly claims and draw down some FFP to support the administrative oversight, again, of all of the Medicaid components, right, of your AFBSS service delivery. So really important there just to kind of tease that out. All right, next slide. There's a couple other funding streams that we do want to touch on here, insurance and third-party payers being one of them. Obviously, as you're delivering services to these clients out in the field, AFBSS may be delivered to clients that have commercial or other payer sources. And so billing those revenues generated will be something to braid in and finance the sustainability of the team. County general funds, to the extent that those are available, acknowledging that very often county behavioral health departments are not recipients of a large share of county general fund, but if they are available, they would be a resource that you would consider braiding in to support these teams. And then also projects for assistance with the transition for homeless, right? So the PATH McKinney grant. So PATH can be relevant where AFBSS activity is focused on individuals experiencing homelessness who have a serious mental illness and a co-occurring SUD need, right? In that context, then you may be able to use your PATH funds to support the outreach, engagement, the screening activities that align with the grant's purpose. But PATH is narrow. So it is not a broad AFBSS operating fund by any means, and it's not appropriate for every population, right? So counties should think of PATH as a targeted resource that may support the specific slice of AFBSS where that population and where the activity aligns. And I think really, as I've kind of gone through these funding streams, the key theme is that it's all about braiding in all of the unique funding streams that the county gets at any given fiscal period and sort of making them all work in synergy with one another because each of them serve a distinct role. AFBSS is doing so many different things when we think about all of those non-billable components, the outreach, the trust building, et cetera, and then the billable components that you've got to consider really kind of an all of the above approach for braiding in your dollars and making this model happen. And we can go to the next slide. So I think the main takeaway from this section is that, financing AFBSS is not about identifying one perfect funding source. It's about aligning several funding streams around the model of care. Many of the core funding sources that we've discussed, BHSA, realignment, Medi-Cal, Sub-G, opioid settlement funds, they're going to carry existing, or they're going to already be carrying existing commitments. So the county is going to need to be, realistic about what's actually available. Sustainability is going to require more than just finding those dollars. It's going to require thinking about how AFBSS fits into your current delivery system. How can you connect it to programs and pathways that already exist to sort of minimize that upfront financing impact, right? And we're going to talk a little bit more about that in some of the subsequent slides about how you can leverage those existing infrastructure in order to, bring in the AFBSS model. Then the next slide. Okay, so, creative approaches to meeting the expectations are critical. So as counties think through implementation, one of the most practical questions is whether AFBSS can be built into something that you're already doing rather than standing up a completely new program. For example, if you already have a mobile crisis, homeless outreach, DMC ODS care coordination, that is existing out in the field.
I think this just adds a little more substance to the creative approach you were really encouraging everyone to take on the previous slides. And I think just to back up for 1 second, all of us know how incredibly important this work is of reaching people who are the most vulnerable, who are struggling with substance use disorder, many of whom are experiencing homelessness. And we know that it can be life or death to get people access to the care they need. So this is incredibly important work. And as Ryan's been saying, we also know that capacity challenges, resource challenges are real. And finding the funding and the staffing and the wherewithal to stand up standalone programs can be really challenging. So, like, in addition to thinking creatively about braiding the funding part, and I think you'll hear more about this when the counties speak, is thinking about how do we braid the service components of this into other existing capacities. And I think a lot of the previous webinars touched on this as well, but it's just worth reiterating, especially for small counties where the volume of demand is probably not going to keep a standalone team or service busy enough to sort of pay the bills. How can you braid these services into other existing activities that you're funding, like mobile crisis or homeless outreach teams? Can you add an AOD counselor? Can you link that team to a MAP provider? Can you add a virtual MAP prescriber if you're having a hard time getting same-day access in your community, and set up a protocol for accessing that virtual provider in a very timely way? Can you partner with, like in Nevada County, one of our FQs was trying to stand up a same-day MAT access clinic and was being underutilized. Great. We have a street outreach team. Let's partner those two things together and create the access that way for clients and kind of both be a part of that solution. So I think it's really, as counties are very excellent at doing, it's really thinking creatively about how do we meet this real life need as well as this requirement, while being mindful of the realities of our constraints and still find a way to do something.
Okay, let's go to the next slide, please. Okay, so really quick, just want to touch on when you consider, we've mentioned a lot of this concept about braiding funding. We've mentioned all of these different funding streams and, some different concepts like Medi-Cal claiming. I do want to point you to the Cal Mesa Behavioral Health Fiscal Academy. I see the link has just been put in the chat for everyone who's in the attendance here today. And what you're going to find there is there are 9 distinct sessions that go over pretty in-depth, a lot of core behavioral health fiscal topics. The first one being every funding stream that was known to me at the time that we created that session 1. So all of the funding streams. The next piece we talk about in that is what does it mean to braid funding, right? That's different than blending, pooling. Braiding is specific. So good information there. The next piece is all about Medicaid reimbursement. We've got a session dedicated to understanding, Medicaid claiming complexities, things of that match, what patient care revenue may and may not be used for, and some other things about budgeting realities with BHSA, what BHSA can be used for, that kind of thing. So I'd love to point folks in that direction. It's a great resource for you to review. Thank you.
Very good. And very quickly, I will share with you too. You all are probably aware of the fact that Boston Consulting Group, or BCG, was contracted by the Department of Healthcare Services to provide some support on billing related issues at the local health jurisdiction level, really with an eye toward identifying and utilizing public funds and other mechanisms, including the attendant activities related to those, to optimize federal financial participation, or the drawdown, the match. And so they created a number of different modules, 17 in all. They're on these next 2 slides. These first 9 modules are all about billing service capture, and you can see they go from validating billable activities to diving into that somewhat opaque targeted case management and related activities that Ryan was alluding to. And on the next slide, additional categories are focused specifically on providers, including productivity standards and related supervisorial activities and requirements. fiscal and data-driven performance management, and being able to track your FFP and maximize FFP in those procedures. And then finally, billable service design. I'll point out to you at the bottom, it says that these are available on the DHCS County Portal Support Center. They're actually kind of through the DHCS County Portal Support Center. So if you don't already have access, you need an invitation to be able to access these particular modules. And so at this point, I would love to, if you'll go to the next slide, introduce our two counties. You already heard our provider names. It's Elise and then Glenda and Mark. We would love to hear from you all about your experience in addressing budget and sustainability kinds of issues. We have Elise, Lake County, up first.
So in Lake County, we have a county-operated mobile crisis program. Not to brag, but I will a little. We had the first approved mobile crisis implementation plan in the state of California. We're incredibly rural and we have a giant lake in the middle of us. And so it takes like 45 minutes, an hour to get from like around the lake to any other point around the lake, which obviously makes some challenges. It's also important to note that we're DMC ODS county. So we're looking at our DMC ODS rates and coverage. This is going to be a really, maybe a different story for just straight drug Medi-Cal counties. So with that said, just like Ryan was saying, our 1991 and 2011 realignment and our BHSA, like all of those are already pretty much maximized to draw down federal financial participation as our local match to the extent that it's allowable and possible. And so our model of looking at this is just like the others have said, we're not trying to make a brand new team. We don't have the providers to do that. We're a healthcare workforce shortage area real bad, just like the rest of Northern California. We struggle with licensed providers of any provider type, let alone prescribers. We don't have not one internal county funded like county position that's a prescriber. All of those are contracted out for us. So that, you know, even our nursing staff is all contracted out. That's how short it is. And so the easiest thing for us, the lowest hanging fruit, which I know is kind of a controversial term, is to embed that SUD person and prescribing capacity into the mobile crisis team. We were a bit forward thinking in this because mobile crisis is an integrated benefit. We were a pilot county for the DHCS integrated contract. Of course, the BHSA is an integrated plan, and we took integration very seriously. And so actually, before all of those were dreams, we were working like, how can we better integrate because we knew the need. And so it's been actually nice to see the administrative and technical side catch up to the service reality that we were experiencing. So we already had an SUD counselor, KDAC, on our mobile crisis team. We already had capacity for via telehealth. So a tablet, like the person sits with the beneficiary in the community and facilitates that telehealth session with a tablet. If medications are prescribed, they are going to take that person to the pharmacy to help pick them up. We're also working to partner with our public health department for mobile services, period, but maybe embedding AFBSS capacity and utilizing our community reinvestment funds. We have like this trailer, basically like this RV, a Winnebago, if you will. And so that's going to turn into a mobile clinic where we can also do like public health can do STD testing and referrals and things like that. That's still in development. Actually, I'm meeting with them this afternoon to finalize those plans. Counties would have been required to submit their community reinvestment plans to the managed care plan last week, I think. So, but anyways, just as a consideration. And just looking at like the funding matrix, just to drive home the point that this is not a one service that you bill. If it is a billable service, it aligns with a specific provider type and CPT code. And of course, counties have to factor in their local share of cost, right? So we know in Lake County that the majority of our payer mix, our beneficiaries, have a 50-50 aid code, which means that if a service was $100, the county has to pay $50 of that service, and then we get $50 back. And so your aid code may vary But it's important that you kind of assess and do that math so that you're able to purchase that service from your local dollars. So I guess that's my 5,000 mile per hour spiel.
That's really helpful. Elise, you did a great job. I'm really impressed. Glenda, Mark?
Thank you. I'm going to provide a high-level overview, and then Glenda and I can answer questions as they come up and provide more detail. So like Lake County, Orange County is building their AFBSS on existing infrastructure. And a few things about Orange County to give everyone some context. Orange County is a populous county of approximately 3.2 million. We have 34 cities, and we are actually the smallest city in Southern California with about 950 square feet if you include water. When we look at our county, we kind of have north, central, and south regions identified. So we have, as you can see on the slide, three key initiatives and strategies. The first one is to enhance our existing outreach efforts to ensure an overall targeted outreach strategy that is data driven and utilizing data such as heat maps and overdose data. So we want to make sure we have a coordinated field engagement plan and strategy. And we have been looking at this data, but we want to really do it in a more enhanced and formalized way. The second initiative is expand the capacity of our county SUD clinics to serve as rapid entry points for treatment, aligning workflows and referral pathways, and ensuring there's no wrong door. So for example, like with our FSPs, we want to make sure that we have these streamlined processes and referral pathways. To give you a little context of Orange County too, we have 3 county operated outpatient clinics that are located in each one of those regions I mentioned, and we have 9 county contracted outpatient sites. So our thought is to do some of these enhancements at our county operated clinic first, and then take what we've learned and expand it to our county contracted sites. And finally, the third key initiative is integrating mobile NTP program units as an extension of our broader SUD continuum. We have a narcotic treatment program provider with already 2 units that are ready to go and already providing some services. These units are tied to 2 of our 5 NTP sites. So that will be a key component to our targeted outreach and number 1. Like Ryan mentioned, we are using multiple streams of financing. We are using a braided funding model and we're also Medi-Cal DMC ODS County, and we're also counting on Sub-G realignment, county general funds, and of course, the Behavioral Health Services Act funding. Key to all of this is partnering with our SUD providers that I mentioned. Also, we have 10 sites that provide residential treatment. Our 2 managed care plan providers, federally qualified healthcare centers, and CBOs to support a coordinated system development and coordinated to inform community need. These are some initial thoughts on how we're approaching this, but we realize that this whole process will be evolving, and we look for opportunities with our community partners and some of the creative ideas that Phoebe suggested, potentially doing some MOUs and seeing how we could really move the needle for the entire county and leverage all our strengths. So I'll stop there, but those are some of the things that we're planning for Orange County.
That's spectacular. Thank you. Thank you so much, Elise and Mark. Mark, I want to just ask you to talk a little bit about Matt Connect and the degree to which that may have helped you identify some support for prescribers.
Yeah, sure thing, Helen. We have Matt Connect that works with our managed care plan and that works with federally qualified healthcare centers, and they really do a great job with linking individuals, our high-risk population most likely to overdose, including individuals involved in the juvenile justice system, coming out of custody, and people who are unsheltered. And they utilize individuals with lived experience and do a great job with linking people to services. So we do a lot of, we collaborate a lot, and we refer to each other. And Glenda, do you have anything to add to that overview?
I can perhaps jump in a little bit
Sure.
because HMA was sort of involved in that a little while back.
Great.
The county organized health system in Orange County, Cal Optima, put up $10 million about 7 or 8 years ago, explicitly to provide training and technical assistance to FQHCs so that they could create kind of a pipeline of MAT prescribers. And I think that has helped expand the number of prescribers you have. Glenda, do you want to add to that?
I was just going to add that Matt Connect is really active and also going to our county jails and being able to support discharges and, ensuring that they are getting linked to any of the services that they need for continuity of care. Really excellent work that they're doing out there.
Yeah, so kind of a unique benefit, in that county in particular, if we could get partnership up in the north and some of the other managed care organizations to support that kind of training and TA to build more prescribers, that would be just spectacular. So let's jump in with some questions. We've talked a lot about some specific strategies, and we'll review the strategies we've talked about in just a second. But I'd like you to share maybe some additional things that we should consider, counties should consider to make implementing those strategies work. So, for example, documentation is a real big deal, right? When you're trying to draw down FFA or you're trying to be able to qualify for reimbursement. Documentation, what other kind of considerations did you all focus on or should counties focus on that we haven't talked about?
I can speak for Orange County.
Sure.
In Orange County, some of the strategies really we've been discussing would include, as Mark mentioned, really our enhancement to existing SUD clinics that will focus on strengthening our walk-in access. And really the focus right now for us is streamlining intake paperwork and clinical workflow. This would then enhance and ensure billing for reimbursable services that can happen as soon as possible. Also working very closely in improving our coordination of care within our FSB teams to support warm handoffs, continuity of care, as mentioned, by aligning workflows, training, and referral pathways. Those are just some of the considerations we are thinking in Orange County.
Yep. Sounds great. Others have thoughts about that?
We're a smart care, Cal Mesa, semi-statewide smart care county. And I know that there's an option for AI supported documentation. I can't remember the platform name now. I'm sure one of they do, but it's looking pretty good. So I mean, like, it's always the same game. How do you get clinicians to have as much time possible for the people work and not as the least cumbersome amount? Because when I have a clinical background and it's not your favorite part usually. And I was notoriously struggling to catch up on my notes. So like, how do you reduce that burden? I mean, and getting really creative, like we try to already with our mobile crisis team, they have their VPN hotspots. And so when they're out in the field, they're sitting in their car or at a park bench, or where I used to do this all the time, like wherever I can, because I would prefer to be outside, sit down at the park and do your note, right? That it's just really meeting clinicians where they're at in their reality and trying to support that.
Yeah, for sure. Ryan, Phoebe, any other kinds of considerations like that you think counties should be focusing on?
I think
I think
Glenda and Elise articulated it so well. And what I love about it is that's like on boots on the ground perspective, right? And I appreciate that. So I
Yeah.
don't have anything to add to that one.
Okay.
The only thing I'd add is I think sometimes I started my career in homeless services, and that's, traditionally was sort of outside the Medi-Cal system or Medicaid system. And documentation expectations are really different over there, or were back then. And so sometimes I feel like we're doing a little bit of blending of cultures as we weave a broader array of services into what were sort of traditionally healthcare services. And so just being patient with sort of the training and sort of culture shifting for some of the workforce that we're weaving into our system now, I think is really important.
And
that sparked something for me because we, in the transition of to the new BHSA, we had to sunset a few programs and transition things right to fit within the new structure. And we had a lot of staff employed as peer support specialists. All of them were certified, so theoretically could bill, but we really hadn't, for a number of reasons, had the capacity to lift them up to get to that point. But now it's like go time, baby. So, but I don't. Peers are still, to me, especially in this treatment modality, like probably the most powerful thing that you could put in the field. And so really supporting those peers and making that as easy as possible, because a lot of our peers may not have even ever really used a computer, right? But yet the value they bring to that field experience and getting people to engage and come into treatment is worth the effort.
Yeah, and I think one of the things that we've been hearing from a number of counties and from our street medicine collaboratives, collaborators, is the notion that as you set up your workflow for working out in the field, you want to use those peers, those community health workers as your front guard. Those are the folks who go out ahead of time, ahead of anybody else on the team, and set up the appointments, identify what procedures for all intents and purposes may need to be done for your clients. And that way you've set up the whole schedule, as it were, for your licensed, more expensive folks. So when they get out there, they can just go boom, 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 and take care of the services that they need to take care of and not necessarily spend their time I mean, they have to create relationships. Obviously, they have to build trust, but they're not doing all of the outreach work that your peers are much, much better at anyway, right? Elise, I'm gonna pick on you a little bit and ask you to tell us a little bit more about maybe any other sustainability challenges that are most important for small and rural counties. And Phoebe, if you want to chime in after she offers some thoughts, you can do that too.
Well, I think it's kind of in line with what's been mentioned before. We have limited staff capacity. And so when we plug staff into programs, we can't afford to use a poor dead time, right? Like we need to be able, because at the end of the day, the math has to math. And so an empty schedule sucks for everybody. And so how do you maximize, again, from a billing perspective, like when there are no shows or where there is that time to try to capture something? I just cannot thank Ryan and his team enough. We just submitted our first admin and QI claims, and that was massive. And it's going to be a tremendous help for us. And also ISL I'm still figuring out to the extent that ISL will fall into this and capturing, not that those are billable, but just being able to show the time that you're spending. But don't sleep on the admin and QR claims. I mean, obviously flexibility, like small rural counties are nothing if not scrappy. And so being willing to pivot very quickly, obviously is a strength I think that we've had, and being able to, not throw good money after bad, so to speak, but like, okay, let's pivot and do something else and try something new.
How much partnering are you doing across county lines?
Across county lines, not as much as we could. In county lines, like that's our whole life, is partnering and leveraging those in-county partnerships.
Okay.
Like for example, my chief of probation, I used to run wraparound groups with her, and now 10 years later, I think we could do more in terms of regional partnerships, especially for meeting really difficult to obtain service modalities. This wouldn't necessarily fall into that, but it's definitely a consideration.
Sure. Phoebe, did you have other thoughts to add to that?
Yeah, I think just reiterating really what Elise is saying, like at the end of the day, you're still running a business, even though it's a public behavioral health benefit. And um, it you've got to people have to be productive. Like our whole system is built on a level of productivity of staff. It's a fee for service model. There's not just revenue sitting there coming in no matter what you do. And so I think that's particularly challenging for small counties where sort of the end you're working with is very small, and how to therefore have your staff have multiple functions so that they can pivot from task to task. If nobody's dropping in for this, how can I switch over to that? We were running a drop-in mat program in Nevada County, which is on the bigger end of the small county universe, and we were grant funded and nowhere close to having enough productivity. And so I think it's really going to take some creative thinking about how to make these things work.
Yeah, for sure. For sure. I'm not seeing a whole lot of raised hands, so I'm going to keep going. I didn't hear a lot about this. What are we thinking about telehealth, particularly using telehealth for MAT prescribing?
It's all I got in some cases. Would I love to have a real
Great.
physical,
Great.
yeah, obviously, and then like here's reality. So like I said, we're in some cases we are already doing this for mobile crisis, and so that's why it's not such a big stretch for us to do this for and for any kind of SUD or MAT service in the field. But like here's the doctor on a tablet, like there's even a stand for the tablet. You know what I mean? You need a little bit of a private space, and then that peer ideally could help with that situation, or that community health worker, and then help them get their meds filled or whatever it is. But I think that's the norm for most small rural counties. Yeah.
And so what humps did you have to get over to make that more acceptable, both to the county powers that be as well as to the provider community?
It's interesting. In my experience, patients were the least resistant
Yeah,
to it.
yeah,
Because the
yeah.
providers felt some type of way about it. They felt weird, and so I think now that they've had more experience with it, and it is a matter of pushing people past their comfort zones. Like we don't live in a comfortable zone.
Yeah.
But I think now they've seen it work, and they're like, okay, this is all right. Like is it the most perfect thing? No, but is it good enough for here? Yeah, and perfect is the enemy of good.
Yeah, for sure. Any other thoughts or questions out there?
I think one of the things, Helen, that you raised earlier that I really appreciated was the having the peer performing so much of that initial coordination. And what that really raises from my perspective on the finance side is that peer support staff have a very high return on investment, right? So the cost for maintaining those positions relative to the value you can draw down from their billing, and really just the value that you get from them out on the field. I think the clients really enjoy that interaction too. So it's kind of both ways, right? Great for the financial, great for the client interaction. And then bringing in telehealth, so having that prescriber just available on demand, I think that is also another good consideration about how can I alleviate the fiscal pressures, right? So get my high ROI staff out there in the field who are present, and then as needed, some of these more costly providers that need to be brought in, they can be brought in ad hoc, right? And so just some different things that sort of help mitigate those costs.
For sure. Absolutely. Let's go to the next slide, a summary slide that kind of hits some of those high-level strategies that we talked about today. We talked about optimizing Medi-Cal reimbursement whenever and wherever that is appropriate. We talked about building on and existing on programs, the lifeblood of all of us, right? I think trying to implement AFBSS, and we had some specific examples in the two counties. Obviously, lots and lots and lots of braiding of funding sources. And oh, by the way, we didn't talk a lot about how DMC-ODS, being a DMC-ODS versus being a DMC county may influence your consideration. Maybe we have a minute to do that in just a second. We talked a lot about the importance of embracing telehealth and getting over the provider angst about that and partnering with other providers, both inside the counties and particularly for smaller counties across your county borders as well. And those regional partnerships fit right in there. Any comments about whether or not being a DMC ODS versus DMC county changes how you're thinking about things?
I may be wrong, and I'm hopeful that Ryan or somebody smarter than me knows this, but is peer support services billable in straight up DMC?
Yes, it is. It is.
Okay. So that'd be the major one. So it's the same there.
Yeah. Yeah. Okay. Good. I just want to take the opportunity to really, really thank our panel. All of you were spectacular. You are spectacular in your work. We honor the work that you do every day, and you are spectacular in taking the time to put all of these thoughts together to share with the rest of the counties on the webinar. So Meyer, take it from here.
Thank you so much for joining this webinar and for joining our AFBSS webinar series. If you have any questions at all, please don't hesitate to reach out to us at any time at info@afbsstraining.org. Thank you all and have a wonderful day.